Hello, and thank you for joining today's segment of Dentons Dialogue U.S. Policy Perspectives. We have a wonderful program in store for you today. Before we begin, we have a few housekeeping items. Please note that today's webinar will be recorded and circulated to all participants. Should you have any questions that you would like to submit to the panel for discussion during today's program, you may submit them through the chat box at the bottom of your screen. If we cannot address your question during today's webinar, we will follow up after the program. With that, I would now like to turn things over to Public Policy Principal John Russell. Over to you, John.
Thank you, Maddie. Good afternoon, everyone, and welcome to the Dentons Dialogue series. We hope on this Friday afternoon, you and yours are safe and well. We've got an all-star team here to talk about healthcare policy in the Biden administration, and we're pulling from two different, if you will, buckets here at the Dentons. We'll have the policy professionals talk, those be Governor Howard Dean and Sandra Lurie, as well as our legal team, who will be joined today with Holly Lutz, Summer Martin, Bruce Freed, and Charlie Luban. We think that providing both, if you will, the policy and the practical brings the most light to an area, a policy area, where we expect a heavy amount of activity in 2021 and through the next year. So let's start off with you, Governor Dean. First, nice to have you on a Friday afternoon, but with Democratic control of both ends of Pennsylvania Avenue, what does that mean for healthcare policy? No, we're no longer repealing and replacing. What are we going to do next?
It'll be very, very difficult because of the narrow margins. Joe Manchin essentially is going to be able to veto anything he wants to veto. And that's true, really true of every other senator. I pick on Joe because he's probably comes from the most conservative state that any Democratic senator comes from. So the working room inside the legislature is going to be incredibly narrow inside the Senate and the House. I think it's fairly obvious that the chairman of the various committees make a huge difference. Here's what else to look out for. A lot of policy is not just determined by the president's policy. It's determined by the personal relationships between the people who get to these appointments. Some of the most important we don't have yet or don't have confirmed. And it's also determined by the strength of the ability to advocate inside a small number of people who are trying to design programs. That's first. Second of all, a lot is going to be done by executive orders, and huge amounts have already been done. A lot has been done, for example, by the DOJ withdrawing from the ACA case before the Supreme Court. There'll be a lot more of that. So if Neera Tanden gets to be OMB director, my prediction is she's going to have a lot to say about healthcare, since she basically was the maven that got Obamacare developed and through the Congress. The director of CMS, who we don't know who that's going to be. Bruce has some insight into that, but that's a very important position. And there are many other positions, some of which are not well known inside CMS, that are going to be incredibly important in the nitty gritty. Whether there's going to be a Medicaid expansion, the change in the politics at the state level, because many rural hospitals have gone broke in those states that did not take the Medicaid expansion, and so there are Republican members of boards of hospitals who are putting pressure on Republican legislators and Republican governors to take the Medicaid expansion because it makes their life easier. Finally, now that the ACO has been in place, the Accountable Care Organization, what we've fundamentally discovered is these are giant monopolies that are sucking in all the physicians. It's almost impossible not to be affiliated with an ACO and still have a small practice, simply because admissions privileges are involved with this, money is involved with this. So there's going to have to be some kind of legislation, which could be bipartisan if we can ever get rid of this horrendous partisanship that we've got going on, in terms of how you support rural hospitals. Because the Medicaid expansion is not going to be enough. The flow is now all towards the ACOs, controlled by large bureaucratic organizations, whether they're for-profit or not for-profit. So I predict, and I'll just turn this over back to John for the learned panelists, and they are all very learned. I predict a much bigger change than we suspect, but not so necessarily because of what comes out of Washington, but because of what market forces as a result of ACA have done, which nobody predicted. And I think a lot of the people that voted and supported ACA did not understand fully what was going to happen simply by pressure of market forces as well as government policy.
Well, Governor, before we move to move on to the rest of the panel, is the ACA here to stay, and we should be seeing it as this is where we are today is the floor, not the ceiling?
Yeah, the ACA is definitely here to stay. Whether whether it maintains its present form of buying insurance through an exchange, which is subsidized based on income, is another matter. But the healthcare establishment, which is essentially almost 20% of our gross national product in the largest economy on the face of the earth, is not going to fundamentally go back to what it was done before. The ACOs are here to stay, which fundamentally changes the doctor-patient relationship and the doctor-hospital relationship. So yes, our healthcare system has been transformed, and sometimes in ways that the authors of the ACA didn't expect. But I think we're not going back. It's impossible to go back and rearrange 20% of the gross national product of the United States.
All right, so Bruce, with that as kind of the table set, let's talk a little bit about who that we know of, and of course, I think we're allowed to speculate a little bit on this, who we think may be coming into the Biden administration.
Well, you'll be happy. You'll be happy to hear I brought my crystal ball.
Very good.
So we'll gaze into it a little bit. There are a few things we do know. We do know that President Biden has nominated Javier Becerra to be the Secretary of HHS. As everyone knows, Becerra was formerly the Attorney General for the state of California, but importantly, before that, was a member of Congress who spent a good bit of time focused on healthcare issues. Notwithstanding that, there's a fair amount of curiosity about why an Attorney General should be the Secretary of HHS. And I think we're going to see, as his confirmation gets started and moves ahead, there'll be a good bit of questioning of him. But my guess is at the end of the day, Secretary Becerra will be Secretary Becerra, and we'll move along. I would note among the things that he demonstrated a lot of interest in when as Attorney General was enforcing antitrust laws, particularly with regard to very large healthcare organizations. It's a matter of public knowledge, but he led the charge against the Sutter healthcare system in Northern California. He's also quite interested and focused on the insurance industry. And again, while Becerra doesn't have anything really to do, in a sense, with antitrust enforcement, there will be something to that as he moves forward. The only other name that we know for sure with regard to leadership positions at HHS is Dr. Wachelle Walensky, who is now the director of the Centers for Disease Control. I think that's a demonstration of the urgency that not just the administration, but the Congress felt in putting someplace in the driver's seat at this critical agency in the midst of the pandemic. That does lead us then back to CMS. And as Governor Dean pointed out, there's sort of wise speculation, might be a good way to describe it, about CMS and its various centers. As the administrator, the two names that seem to have come to the top are Chiquita Brooks LaSure, who was the co-lead of the HHS transition team. She spent a good bit of time during the Obama administration at CMS, very well regarded. I think she's better known as having excellent political instincts and strategic instincts about moving policy along. But she's clearly a contender. The other name that we hear is my friend, Dr. Mandy Cohen, also was very senior at CMS during the Obama administration, and since then has been the Secretary of the Department of Health and Human Services at the state of North Carolina, where she played a very important role in developing a comprehensive strategy with providers and insurers to move ahead with value-based reimbursement and all of that, all that that means in terms of increased focus on value, back to the ACO issue that Governor Dean pointed out, moving up quality while controlling costs. So those are two names for you. Should either of them not, well, one of them obviously will not be the administrator, perhaps neither of them, but both of them then are sort of suggested as the principal deputy, the number two. And again, they would both be exceptional leaders. One other name that many people are curious about is the director of the Center for Innovation at CMS. And on that one, a name that many people will recognize, Liz Fowler. Liz was at the White House during the Obama administration, played a pivotal role in the formation of the Affordable Care Act and the implementation of its various regulations driven from the Domestic Policy Council. She's terrific, big thinker, and I think she would be great. I could go on, John, but
well, let me kind of spin it here a little bit. You've seen that the Biden administration has brought in a climate czar.
Yes.
You haven't, and they've talked about how the climate response is going to be across the whole of government. You're not necessarily seeing that. Now let's take COVID out. As you know, that was a call we had 3 weeks ago, right. So we won't necessarily focus on that so much, but we certainly have a COVID team in place and kind of separate and apart, if you will, from the usual suspects. But should we read into anything that the Biden administration has certainly prioritized climate and brought in a czar? Doesn't sound like they're doing that for healthcare, writ large, not COVID. Does that matter?
Well, I actually disagree with you. I think, again, Governor Dean's point about the importance of Neera Tanden at the Office of Management and Budget, as many on this call understand, OMB is at the top of the pyramid. Nothing comes out of regulatory and policy-making agencies that doesn't ultimately get reviewed and blessed, or more likely revised by the team at OMB. They report directly to the president. So I think Neera Tanden is going to play a very important role there. But obviously, Mr. Becerra, and again, the leadership at CMS, there's a bit of a triumvirate. After all, as again, Howard pointed out, we're only talking about 20% of the nation's gross domestic product. It is the tentacles, that may be not the best way to describe them, but the reach of healthcare into every aspect of our life. It's almost impossible to believe that one person could have overall czar-like responsibility for that. It's clearly, this is where having a team is critical.
Okay, well, thank you. I'd like to, Sandra, if I could kind of move over to you, if you will. It sounds like we've got Team Obama ACA coming into positions at the in the Biden White House. But we've got action on the floor, or soon to be on the floor, but certainly at the committee level and in the Congress right now, that does impact the ACA, that does impact the relationship between states and the federal government. I'm wondering if you wouldn't mind kind of giving us an overview of, in this COVID relief package, what are we talking about in terms of healthcare?
Sure, thank you. I would add on personnel that the deputy HHS secretary nominee is a woman named Andrea Palm, who's a former Senator Hillary Clinton staffer and Obama White House person in HHS. So she's now runs the Wisconsin Department of Health, and she'll be coming back to Washington. But yes, even though this first package is supposedly COVID and the 1.9 trillion, there's lots of money for healthcare in this. Most of it is focused on vaccine distribution and other parts of the supply chain to make sure that the product moves quickly into people's arms. But there are also a couple of things in there that are just sort of little pushes towards greater coverage under the Affordable Care Act. There's a 2-year increase in subsidies for lower to mid-income folks to purchase plans on the exchange. There's, Charlie will talk about this later, but there's also a 5% little incentive for states that have not expanded Medicaid to expand Medicaid. There's also a couple of big infusion for community health centers and a new tax subsidy that's temporary for individuals who lose their job and elect to get their insurance through COBRA. That's the first time that purchase will be subsidized. So you can see the beginnings of attempts in this to continue the expansion of the Affordable Care Act and make it more affordable. So there's lots of thought that the next reconciliation bill, maybe in the spring or early summer, will have even more provisions to bolster the ACA.
Gosh, so it's almost stealing a line from the former White House Chief of Staff about not letting a big crisis go to waste.
Right.
We're going to be using COVID here in a COVID stimulus, which I should say for the record, I fully support, not letting a crisis go to waste. But it's an attempt here to really strengthen the foundations, if you will, of the ACA. And Charlie, I think Sandra kind of teed you up for this, but you are, as we joke, Mr. Medicaid. What does this mean? Are we in fact seeing the COVID package being used to strengthen the tenets of Obamacare?
Well, certainly in certain areas, and I'm happy to talk about the Medicaid areas. I do think that what a major priority shift for the Biden administration as opposed to the Trump administration will be a focus on coverage and increasing coverage. And there are ways to do that through the exchanges, and there are ways to do that through Medicaid. There are also ways to do it through Medicare, but that actually would take much more difficult legislation than anybody's talking about right now. But on the Medicaid side, in some ways, the low-hanging fruit of expanding coverage is getting the non-expansion states to pick up the Medicaid expansion. And as Sander mentioned, there is this incentive, a pretty substantial carrot, where for 2 years, if you're a non-expansion state that has never expanded Medicaid or never expanded in response to the ACA, for 2 years, you will have a 5% bump in your FMAP for your entire Medicaid program, not the expansion population. There was some confusion in some of the press that sort of said, instead of a 90% match, you'd have a 95% match. That's actually not the proposal. The proposal is that if you expand Medicaid, your FMAP will be increased by 5 percentage points on top of the 6.2% FMAP increase that exists for the COVID public health emergency. That basically shifts more of the funding for the entire Medicaid program onto the federal government. It is a 2-year limited window, but I mean, depending on how states are feeling about their own finances, it may well be enough to get some of those really pretty substantial states to maybe think about taking that jump. I mean, the big states are Florida, Texas, Georgia, North Carolina, all sizable states that have not yet expanded Medicaid. And I think this legislation is intending to really focus on those, see if there are ways to get those states to move. There are other coverage expansion items that are in the COVID package. I mean, there's a new option for states to extend postpartum coverage to new mothers for 12 months. Right now, that coverage is often limited to 60 days. And so there are some much more minor tweaks out there like that. Also coverage for COVID vaccines, as well as as well as treatment and testing. So there are things like that. And then I don't know, John, whether you want me to talk about it now or sometime later. I mean, there's also stuff happening, even outside of the legislative context.
Well, let's put a pin on that and move to that. But yeah, that we do want to talk about that because I think it's a great, and you gave me the segue, so I really appreciate it. Thank you.
I'll do what I can.
To some of the practical attorneys, shall we say, on the screens in front of you, because we do see market forces really driving the process here, if you will, or driving the outcomes. Maybe is a better way to say it. Summer, I'd love to talk to you because I think over the last year, it's been COVID that's been really driving this. And gosh, I looked at my calendar. We are getting close to that 1-year anniversary of not coming into offices, which is hard to believe. But if you will, in the remote world that you've been living in, how are you advising your clients, juggling what's going on now, if you will, in the world of COVID that has, to say disrupted would be, I think, the very least you could say about it.
Yeah, it's a great point, John. I mean, one of the things that we've really been grappling with over the past year is, being heavily regulated through sub-regulatory guidance, right? As opposed to the standard notice and comment rulemaking process. And also a reality for a lot of providers and probably others, but particularly in healthcare, of being what I would call a true government contractor, right? We're very comfortable with our revenue from Medicare and Medicaid healthcare programs, but because of the necessity of the pandemic, billions of dollars just went directly from the federal government to providers. And so now they're struggling with, what does that mean for me? And to give an example, a lot of the guidance tied to those dollars is sub-regulatory in the form of FAQs. And those FAQs were changing sometimes on a daily basis. And in the midst of all of that change, we're still having to make decisions and attest to terms and conditions and attest to the government that we're going to comply with FAQs that we're continuing to change. And we're analyzing movement of an FAQ to a different title. And does that mean something? And then actually the next week it goes back under a different subtitle. And so, and then little word changes over the course of now months. And at the same time, we're having disparate guidance from states or from other programs that are providing funding for the providers' operations, facilities, testing, whatever it may be. So it all really, for me, highlighted how important the regular rulemaking process is. That there's a lot to be said for the notice and comment process. And now with the new administration, we're wondering how that will have an impact. And in fact, a lot of rules that the Trump administration was putting out at the very end of the administration are under review. So we're going to see where that lands. We've gotten some answers. So for example, this week, I think, we got an answer from CMS that the Stark Law changes are effective. They are final, but we continue to wait to hear about other rules and where they're going to land. But in the course of that, we still have to do our day-to-day. We have to finalize financial statements, right? We have to see patients. We have to know who to bill. And so we're still working through that. And then I think the last thing that I would mention is that as a result of all of that, we'll really have to monitor how DOJ is going to handle this. DOJ is going to have to decide what is its position with respect to enforcing sub-regulatory guidance documents. What is its position on enforcing FAQs that have changed, probably hundreds of times? So it'll be an interesting dynamic to see, especially around those billions of dollars that really by necessity had to get out to the providers. And now, what will the administration do with respect to how do we report for that? Do we have to audit for that? And then with respect to DOJ, how do we enforce to that?
Well, and you've got two committees in the House and the Senate that have oversight. Well, they all have oversight responsibility, but two directly set up, or certainly in the House, directly set up to look into this. All right, Bruce pulled out his crystal ball. Summer, I'm going to ask you to pull yours out. Do you think we will be, shall we say, implementing via FAQ in this next COVID package, or are you expecting, shall we say, a return to somewhat normalcy?
Well, I think on some things we'll see a return to normalcy, waivers, flexibilities with respect to how we're providing care. I don't know that they will be able to change course on the provider relief fund dollars. There would be a lot of backlash from the industry if there was a move to release a set of proposed or even interim rules, unless they tracked pretty closely to the flexibilities that we have ended up with in the FAQs. I mean, we're still interpreting and trying to understand a lot around allocations, but and reporting. But I think it'll be hard with respect to that program in particular. But in the others, I think we might see moving back into the normalcy after the PHE is over.
Yeah,
I should add that caveat.
Yeah. Which sooner rather than later, one hopes.
Right.
Ollie, I'd love to kind of get your thoughts here. All right, we've been hearing that clients have been forced to, change on the dime, if you will, after an FAQ that changes 24 hours later. I'd kind of like to help. Can you help me look at it the other way, though? Is what are your clients wanting? And you don't get to say clarity, but what are your clients wanting from? From the feds here as they're moving forward, as they're still trying to.
A lot of things.
Go ahead.
They want a lot of things. I was just listening to Summer, just thinking about all those long nights. It was like reading tea leaves. It was just, crazy. But look, there's a lot of things they want. I think that we've been getting a lot of questions, and we have a lot of clients emphasizing the access to care. So I think rural communities are really hard hit to, Charlie's point, maybe some of those, states that didn't do Medicaid expansion might do that. There have been 21, I think, rural hospitals closed, 7 in the last 6 months. I think 2 in Georgia, Florida, 31 bankruptcies filed. So those communities are really hard hit. And so there might be enough. I defer to Governor Dean and Bruce and y'all about what kind of pressure, what kind of lobby they have. But those, communities have been really hard hit. On the flip side, there's some things that the CARES Act did and that changes that CMS implemented as part of that flexibility that were really good that people want to continue. So telehealth is a huge one, right? So during COVID, normally Medicare doesn't pay for care if the patient's in their home and doesn't pay if the patient but for teleneuro in an urban setting. And they said during COVID, you can be in your home. The physician will get paid the same amount as a face-to-face visit. You can be in downtown Detroit. So all those flexibilities have really expanded care, and which has been hugely helpful for the rural community. Didn't help the hospital stay open because people didn't want to go in, right? And so more telehealth visits. But there was something like, 90 million mental health telehealth visits in 2020. And so the mental health aspect of that is another. There's already a chronic shortage of mental health providers. So keeping those expanded telehealth, both the payment and the flexibilities, the flexibilities will take legislation. I don't know, y'all can tell me, to remove the barriers in terms of at the home and, rural setting. But that is something that I do think facilities and healthcare really want to continue that. And, what we've heard from Biden administration is commitment to infrastructure, which will be expanded broadband, which will kind of go towards telehealth. We've talked about ensuring that there are grants for not only specific rural providers, or the rural community, but specific to virtual care. And so that's kind of a train that's going to be kind of hard to put back in the station. I mean, telehealth has been covered for a long time. Medicaid, actually, some states pay for it and, already pay for it in the home. So different than Medicare. So there may be some alignment. But that's something we've seen that's really provided a great use for the community. And I think providers really want that to continue. And the last one was hospitals are able to provide and bill for care in patients' homes as if it was done in the hospital. That'll be a harder thing to keep because that's a lot more regulatory and statutory gymnastics that got us there. So it's different than telehealth. It's the hospital actually billing for something provided in the patient's home versus a doc billing for patient services in the home. I think top line is really the physician access and patient access to more physician professional care.
Well,
Or NPs, mid-levels.
It strikes me, Holly, that you're talking about infrastructure, right? That
Yes.
that has certainly shown over this last year that the healthcare infrastructure in the United States is patchwork at best, and truly failing. So, Sandra,
well, and that's where, well, I guess one point, sorry, on that, which is, hospitals and health systems have been reacting during COVID. Physicians, big systems who have large physician office presence, they didn't have a lot of telehealth. Now they have telehealth. So a lot of the expanded access has really been in the private sector, standing stuff up. And so I think from the infrastructure, how you harness that, the new services and sort of the new participants who are already out there, but how you sort of harmonize that and bring that to a level that only the federal government could do. I think that's where the real bang for the buck is.
Governor, can I ask you a quick question and ask you to put your original professional hat on, or your stethoscope? What do you think of telehealth? You're a doctor. Is this a good thing? Should we be, is this I don't want to call it a flash in the pan, but is this we're only going to see it because of the pandemic, or is the cat out of, or if you will, the cow out of the barn, and we're going to be dealing with this in a virtual world moving forward? Hold on one second, buddy. Yep.
I got you. My wife still practices, and she has found this absolutely invaluable, and the patients love it. Now, she's been practicing for 40 years, so she has a lot of 70, 80, 90-year-old patients that don't get out much. This is so much easier than house calls or than trying to get into the office. The public demand for this is going to be enormous. The first guy I ever knew that discovered this was about 25 years ago, believe it or not, in Lynchburg, Virginia, where a guy took over one of the local hospitals and bought half an insurance company, and immediately realized it was much cheaper for him to send an ambulance, 2 doctors, and a nurse to a dual eligible if they called in on a Saturday night, because once they got in the hospital, you could never get them out, and the government reimbursement ran out after 30 days. So in a system where it's just gargantuan in terms of the gross national product, it takes an earthquake to make these kinds of changes. And I think we're in the middle of that earthquake, and I think telehealth is not going away. There's a huge demand for it, and it's not the least bit partisan as far as I can tell.
Sandra, do you think in an infrastructure package coming forward, how do you support telehealth? Is that broadband and significant amounts of broadband spending, or what do you see?
Well, I think I defer to Bruce and Holly on this, but I think payment changes create, new types of practices. And if Medicare and Medicaid pay 1 out of every 3 healthcare dollars in this country, if they make changes or Congress makes those changes, you bet you're going to see a change in the practice of medicine. The payers kind of control it. And I expect that to be a subject of debate in the future, maybe in the second package, but there's also actually bipartisan interest in telehealth.
Right.
In fact, most representatives in rural areas are Republicans, and where this is vital to patients. So I defer to Bruce and Holly, but it seems to me where the money goes is where the medicine goes.
The infrastructure issue is obviously going to be critical, and it often gets thought of as extending telehealth, virtual care, as many now call it, into rural and frontier parts of the country. But that's not the only place it's going to be reaching. You think about inner cities that have been medically underserved, and this providing new means of serving folks who live in inner cities. But it's important, I think, that we think even beyond what we immediately think of as telehealth, primary care, mental health, to recognize that this is going to be the proverbial rock in the pond. And what we're going to see is new technologies that will be able to be accessed via broadband connections that will allow clinicians to be able to see and care for patients in a remote setting that they could never have dreamed about before. The easiest example might be, for instance, an otoscope that would allow a pediatrician to see the child's ear without having to have mom come into the pediatrician's office in order for the doc to look and say, yeah, that looks like an infection, take this. That it's a ripple effect that I think, again, back to John's point, it's hard for us to be able to project where this will lead.
Well, gosh,
I'll throw in one. Can I just throw in one thing in terms of ripple effect? You're already seeing amazing things with AI, right? And so now teleneuro, there's legislative changes. So now you could, let's say somebody's having a heart attack. Do they need TPA or do they not? You've got a limited window. And so you might be in an inner city, Detroit, downtown Miami, but you might not have a neurologist sort of right there. And so there's just amazing technology that can, take CAT scans, look at the slices of images, use AI, identify the ones that are, show those hot spots that give, help clinical diagnoses more quickly. And not just one of dozens of examples, but I think that's another area that those overlays are going to.
I was going to add to that, Holly, we were talking a little bit earlier about revenue sources. We're also seeing enormous growth in direct to consumer application.
Indeed.
Right. And so now your phone, right?
Our Apple Watches, right? Yeah.
That's right. So it's almost once a week we're getting calls.
Well, hey, you guys had me and I don't have to go to the emergency room at 3:30 in the morning on an earache. So we can move from there. If anything after that is, in my humble opinion, gravy. But to switch it up a little bit, we've talked about hospitals. We've talked a little bit about Medicaid, a little bit about Medicare. Bruce, can we talk a little bit about what should insurance companies be expecting here? What kind of relationship are they going to have with, or the AHIPs and the ACAPs, if you will, the world going to have with the Biden administration?
Listen, we're already seeing it. The Obamacare exchanges, be they state or federal, are now going to have a special election period beginning on February 15th, which is Monday, if I'm not mistaken, for the next 3 months, which is specifically intended to provide urgent coverage, a new mechanism, a new avenue for coverage for folks who lost coverage as a result of their being unemployed. Many of those folks had coverage through their employer previously. So there's going to be a big uptick, I think the administration hopes, in the number of people who are able to obtain coverage through insurance companies. So that number one. Notwithstanding Governor Dean's points about ACOs, let's remember that in many parts of the country, Medicare Advantage and Medicaid managed care organizations are very, very well entrenched. And what we have seen in recent years, and I suspect we'll continue to see, is a continuing growth of eligible beneficiaries, seniors, low-income people, obtaining their coverage through private insurers that are operating under contracts with state or federal governments. And so there again, indeed, I think we've seen that for most insurers, the certainty of government payment, the predictability of it, even with the more complex regulatory schemes they have to adhere to, they're just better customers, frankly, than many employers have been. And I think that certainly came home given the loss of employment-based coverage that literally tens of millions of people felt and their insurers felt. So more to come. The one thing I would say, John, is that this, again, thinking back to Obamacare for a minute, it's not just exchanges, it's not just expanding Medicaid, as Charlie has spoken to, but the growth of value-based reimbursement is here to stay. It is, in a sense, the last best hope to both incent improvement in the quality of care and at the same time constrain the growth and the cost of that care. There's no going back to fee for service. We're long past that. The idea of something simple like per capita payments, the old health plan models, that had its own complexity. I think now we're going to see value-based reimbursement, whether it's through ACOs or directly to providers around certain kinds of services rendered, is going to be what we have to look forward to.
Okay. Well, if I could, Governor, can I kick it on over to you and actually ask you again to put on your stethoscope? We haven't talked about pharma. We spent 4 years talking about drug prices in the last administration, and they just ran out of time to get us our drug cards, or $200 drug card, or whatever that was. What kind of relationship should pharma be expecting with the Biden administration? I'd note it seems that pharma writ large came up with 200 million more doses that the Biden administration of the vaccine that they announced yesterday. Clearly, there's an opportunity and a working relationship that's coming out of this COVID response that is necessitated by this COVID response. But what are you thinking about? What should those in the pharma world be looking at? Do it one more time.
I could keep myself off mute, but then who knows what my grandchildren would be saying on the this is going to be incredibly contentious. There's a huge part of the Democratic Party and a significant part of the Republican Party that would like to really rein in pharmaceutical prices. It's an ongoing problem. The real problem, of course, is a structural problem. Because of the way we're set up, we essentially do the R&D for the rest of the world. They control prices, and if we do, then there's not much incentive for R&D. So pharma's going to have to give in to something. And again, if you see the kinds of people that we're all talking about get appointed, this is some very serious brain power in these, interestingly, almost all women who are going to be running the healthcare system. I mean, these people are experienced. They have run the big game in multiple administrations. They know the stuff inside out. I had forgotten that Liz Fowler was on the possibilities. She is unbelievably smart, and she's also worked for an insurance company for a long time and bounced back and forth in that world. So these folks know this game inside out. I think pharma is going to have to come to the table and do something that's conciliatory. I do not think you're going to see something drastic because I think they also understand the problems with doing the kinds of things that the Democratic left would like to do in terms of wrecking the industry. But they're going to have to get much more serious. They can't just play the resistance game anymore. They're going to have to come up with some concrete ways of managing things like insulin prices, which have really been, I frankly think one of the big problems, honestly, is I've forgotten the name for them. I'm blocking on it, but the people that come in and sell drugs in bulk and think they're saving money. PBMs, yeah, the pharmaceutical benefit managers. And, in fact, that now runs up prices because of the way that the incentives work. So there's a lot of serious problems here. There's a unanimous, almost across all party boundaries, except for a few, belief that something's going to have to be done. And I think Biden is obviously going to show a lot more intensity, and his team is really unlike President Trump's team, which was a joke. This team is really capable and really smart and really tough. And if Biden gets behind doing something, it'll get done, but it won't be so drastic as to wreck the industry, which I think some of the proposals might. Bruce.
Yeah.
Well, I actually have a related question for you, Governor, which is a lot of anxiety, a lot of concern over the lack of U.S. manufacturing of pharmaceutical products. Again, particularly coming out of COVID, not just pharmaceuticals, but PPEs and syringes and everything. Interestingly, I don't know that any of the vaccines that we're all going to be taking are actually manufactured in the United States.
Some of them are. There's a big plant in Michigan. I mean, there are, yes, some of them are, but you're right. A lot of it's in India. Here's what I think about that, just very briefly. This is an issue that's not just a pharma issue. I think major American every major corporation in the world is now going to rethink their supply lines.
Yes.
For the last 20, 30 years during globalization, people have used the incredible advances in both tech and transportation to make their products all over the world and bring them together somewhere where they're made and then shipped into, so the low cost manufacturer. Well, it turns out that it's not so low cost if you can't move anything because of COVID. And you're going to see in every industry, not just the pharma industry, people trying to figure out, well, wait a minute, does it pay me to go to India, or maybe I should just stick with China with Mexico, because it's right across the border. So that, and this is going to happen in the car industry. It's going to happen in every industry you can possibly think of. There was a huge Toyota shortage because they couldn't get Toyota parts into the United States for assembly. And when all the car companies were making a lot of money for whatever reason, in the beginning of COVID, Toyota couldn't supply enough cars. And so all these companies, including pharma, are going to have to think about that. Otherwise, they're going to get hammered the next time something like this happens.
And I think you're right, Governor. It's not just pharmaceuticals. It is that this is
Right.
an introspection of corporations across the spectrum, and supply chains have shown vulnerabilities, and trying to get those. And let's remember, we couldn't get toilet paper.
Yeah.
Remember those days? Oh boy. Well, Sander, kind of can we take a step away from the legislating by COVID, shall we say, or legislating by reconciliation? Clearly, where the margins are, it's tough to get something outside of a budget reconciliation process done. Do you see an active healthcare legislation, healthcare agenda here for the first year? Let's say that. We'll keep it.
Yeah, I think there'll be a major attempt in the second reconciliation bill, but as Bruce has outlined and through executive actions and some of the provisions in this COVID bill, I think this is the first sort of boost to the Affordable Care Act, not to mention all the money for COVID infrastructure. I think there will still be efforts to improve the ACA and support it more. As you know, reconciliation doesn't allow for some legislation that sort of reconstitutes exchanges or something like that. You can increase the subsidies, the refundable tax credits, things like that. But so I think it will be part of the next reconciliation bill. However, I think it mostly is going to focus on climate change incentives, infrastructure, green jobs, et cetera.
You mentioned that it's tough that reconciliation is very specific box of what you can and can't get in there. You probably couldn't get in some language in there that says the federal government or Medicare can now negotiate for drug prices. That might be a bridge too far.
Yeah, no, that might be. Remember, that is going to need all 51 senators in the Senate to support that, and how that is crafted is going to be very testy, and some of it may not be budget related. So you're right. That faces not only challenges within the Democratic Party, but also how you craft it for it to be effective.
Understand. Charlie, I saw you out of the corner of my eye, kind of roll your eyes and move around in your chair a little bit. You got something to add to that?
I was just trying to think. Well, I mean, because obviously the hallmarks of reconciliation, or whether there's a budget effect, and whether it's in or out the 10-year window. And so I was trying to think. Well, negotiating for. I mean, there's definitely a budget effect to Medicare negotiating, but I think it is the politics that Sander was laying out that's really probably going to be most problematic.
Well, what do you see in your world over the next year or so?
Well, I mean, I do think that there's a fair amount that's going to happen just on the administrative side, like outside of Congress. I mean, today, the Biden administration is supposed to be rescinding the the guidance that they issued, that the former administration issued about work requirements in Medicaid. And that will have a spillover effect to 10 states that have approvals for work requirements, even though none of them have implemented them because they've all been hung up in court cases. It will have a ripple effect to a Supreme Court case that's hearing whether or not the work requirements are valid in Medicaid in, I think it's next month. So there are many things, at least in the Medicaid world, that I think will be undoing initiatives of the Trump administration. There's maybe some that actually are just sort of tweaking them in different ways. I mean, nobody's mentioned on this panel sort of social determinants of health, which are a big deal, not just in the Medicaid world, but throughout as well. But I do think that the Biden administration health team is likely to focus on social determinants and, you know, focusing on sort of non-healthcare issues that that affect people's health. And I do think we're likely to see something about that more on the administrative side than the legislative side.
Well, I think what you said there just tagged something. And Bruce, I saw your hand pop up. You want to jump in?
Well, in a sense, it's a leapfrog off of the point Charlie just made about social determinants, moving a little bit further into the urgency, the priority this administration is, I expect, is given. They have said they will give to addressing the social and racial inequities that are so prevalent throughout not just society, but the healthcare system in particular. We've seen this play out during the pandemic in a whole host of ways, now in the vaccination programs in a whole host of ways. I'm heartened by some of the leadership that we've seen appointed that clearly will bring those priorities, which they already have for themselves, into their jobs. And then, of course, related to that, something we've not really been able to talk about so far is really beginning to address the historic underfunding of the public health infrastructure in the country. The inability, well, in some instances, the inexistence of public health capabilities in large parts of the country has really been shown. That is going to take some money. So I don't know what the appetite for that will be from the Congress, but I know that it is something that this administration has got its eye on pretty sharply.
You know what we haven't brought up, and I think I'm going to throw this up as a jump ball, as we've got about 4 minutes left in this. We haven't talked about a certain court case in the Supreme Court at all. And what, again, looking into crystal balls, what we might expect to come out. I believe the case has been heard. If I remember my Supreme Court class, they've already made a decision. They're just waiting for the briefs to be written and to put the decision out. But Bruce, should we still be concerned that the ACA is going to get overthrown by the Supreme Court?
Listen, you never know until you see what the decision of the court is. Certainly during the oral arguments, the body language, the questions, if I'm not mistaken, maybe even some of the eye rolling suggests that there's a little prospect for throwing the baby out with the bathwater, right? We may see that particular issue that the state of Texas first challenged as undermining the entirety of the act. That might fall by the wayside. But I would be very surprised, again, in the midst of a national health emergency, for the court to jettison the entire ACA. Even if they do find some portion of it problematic, I would expect there would be time afforded to allow the Congress, should it be so inclined, to address that particular issue. So my anxiety about the ACA being at risk is less now than it was a year ago.
Governor Dean, I think you're probably responding to a question from one of our guests, but I'd like to, if you wouldn't mind, I'd love to throw it to you. What do you think, or what's going to happen in the Supreme Court with the ACA, with a Texas lawsuit?
I would agree with Bruce entirely. I was chuckling at another question from Gary Goldberg. What do you think would happen if the Biden administration said it intended to exercise march-in rights if they couldn't get more cooperation from the foreign pharmaceutical prices? I think he would instantly go out and hire Dentons and pay us as much as you possibly could so that we could head that off at the pass. That would be the atomic bomb that the administration would hold over the industry. I think the industry is much too smart for that. I think they're going to see that there is going to be trouble with that, and that I would hope that there will be a summit of some sort between the key players, probably not the president himself for political reasons, but certainly the key players, and we've talked about who those are and how smart they are. I think something can be worked out. That would be actually catastrophic for the industry as well, because they would went before the Bayh-Dole, which is where the march-in rights were originally designed to deal with. Before that, the number of patents that were issued in a year were tiny compared to what is issued now. So that's a direct attack on the patents of the pharmaceuticals. It could be done if the frustration in the White House and in the Congress gets too big, but that really is the atomic bomb. And I wouldn't want to drop that on any industry that I thought was really important for the future of the country. But
well, and let's be honest, it's an industry that, say what you will about drug prices, but look what they're putting out here.
Yeah.
In the span of less than a year, we've got what, 3 vaccines, possibly a 4th?
One of the last industries where the United States is far ahead of the rest of the world, along with tech, is the drug industry. I mean, the innovation that's going on here is not going on. I don't see a whole lot of people lining up for the Chinese or the Russian vaccine these days. So yeah, that's right. But you know, I mean, the public has been really ticked off about pricing for a long time, and there's been a lot of problems. Again, PBMs and others are also to blame for this. I think that Joe Biden is going to want to do something about this, and I urge the industry to come to the table with a workable solution, not the usual jockeying that goes on, because I think the public is really concerned about it.
Okay, so we've hit the 4 o'clock, we've hit the 1 hour threshold. That's what we've promised our participants and our guests, but I'm asking for one more question. You are limited to 30 seconds, but I'd ask you to put your crystal balls out in front of you, take a look and see what will be the 1 or 2 great successes in the healthcare space that the President Biden will be pointing to as he's running for re-election in 2024. And Governor Dean, why don't I start off with you? You got 30 seconds.
I'll take less. It'll be the control of COVID-19.
Bruce?
Well, that already having been taken, I think he will be able to say more people have healthcare coverage now than what he inherited. You know, John, let me make one other thing. I know that one of the participants in the conference in our webinar is with the Allina Health System in Minnesota. And I just wanted to extend our sympathies to the terrible situation that happened in your clinic.
Thank you, Bruce. That's sentiment held by all of us. Charlie?
Yeah, actually, I'm going to second Bruce's prediction as to touting the reduction in numbers of uninsured, or the percentage of uninsured in the United States.
All right, Summer, can I grab you before you got to go?
So sorry. Yeah, my thoughts are just initially went where Governor Dean's went, getting control of the coronavirus and
COVID, the top 3.
getting back to normal, right?
Holly, what about you?
I think it's going to be rebuilding healthcare in rural communities. I think with COVID, a lot of people have left big cities. They've gone further afield. They've built their log cabins in wherever. I think it just highlights something I think Bruce had, indicated too, just the the disparity of healthcare, bricks and mortar wise, and I think it's going to be rebuilding rural.
Thank you, Holly. Sander, for once, you get the last word, my friend. What do you got?
I agree. I think it's COVID, but I think COVID and its aftermath will cover the whole 4 years of his term, because we may need boosters and new vaccines starting next year, and we need a public health infrastructure to deliver this on a massive scale like we were standing up right now. I also think while coverage is important, the number one thing that most politicians tell me that their constituents are upset is about the cost of healthcare. Because 95% of our country, 99%, they have coverage. It's just really expensive. It doesn't pay for everything. And that will be the real challenge that Biden has to conquer, is the cost.
Price transparency.
Yeah.
Price transparency. Well, I thought we were going to get a price list of everything from hospitals from our last administration. All right.
It's on the website.
I'm sorry, it's on the website somewhere. I thank you all for joining us. Thanks so much to our panelists. I always feel a heck of a lot smarter when I spend time with you, Governor Dean, and you, Holly, and Bruce, and Sumner, and Charlie. Thank you for your time this afternoon on a Friday afternoon. To our guests, thank you for joining. We hope you found this useful and insightful. Should you have further questions, please don't hesitate to use the email address you saw at the beginning and reach out. We'd be happy to follow up with you in any way you'd like. We'll flag as a little bit of a programming note. We're back at it next Friday. We're going to talk about the Biden administration and technology, which I think technology certainly plays into a healthcare infrastructure, if you will. So if you're interested, we hope you will join us. I want to wish everybody a very, very happy Valentine's Day. It is Sunday. Remember that not everything delivers on Sunday. So if you need to get gifts, get them now. Or as quickly as you possibly can. And there are, at least in DC, there's a run on roses. So they're hard to find. You got to get them in Maryland and then come back down, or so I'm told. Have a happy President's Day, a great 3-day weekend wherever you are. Thank you for joining us, and we'll see you soon.
Thanks, John.
Thank you.
Take care.
Bye,
Bye, guys.
everyone.